your time with me to talk a little bit about family medicine. So we are going to get right into it. I'm going to give you guys a little bit of an overview about myself, my journey, and then hopefully take you into the day in the life of a family med doctor. So we are going to get started here. So a little bit about me. I'm a Pacific Northwest gal. I grew up in the Pacific Northwest from kindergarten all the way to med school. Though I am an immigrant to this country, I came here when I was less than 2 years old. So not much that I know about from the different country or India. But I've been living here for much of my life. Kindergarten through med school is where I spent in the Pacific Northwest, and I hope to continue to practice in this area. Right now practicing in Bellevue, Washington, but from the greater Seattle area is kind of where I have been. So growing up, I always knew that I wanted to be a doctor. As young as the age of 5, I knew I wanted to be in healthcare, and that kind of got me started in terms of volunteering at a local hospital. I did that when I was as young as 15 years old, tried to shadow as many people as possible to gain more access. My parents are not in healthcare. My dad's a pharmacist, but not a physician. But I always knew that that was something that I wanted to do. I have these little stickers posted up on my wall, different pieces of motivation, because let me tell you, it was quite the journey, and I'm hoping to kind of go through that a little bit with you guys today. So upon graduation from high school, all the way back in 2008, I decided to go to Pennsylvania State University, far away from home. I wanted a little bit of a change, and it was quite the change indeed. I was at the Everly College of Science there. It was a wonderful experience for me. I got to learn a lot, be away from home a little bit, which was fabulous. And after a year that I spent at Penn State, I decided, had this wonderful opportunity to study abroad. And I decided to take that up because it was actually at a medical school abroad in a small town outside of Dubai called Ras Al Khaimah. And I was at a medical school there for less than a year, I want to say 6 to 8 months or so. And that experience was truly, truly eye-opening for me. It allowed me to realize the disparities in healthcare, both comparative to the United States and outside of the United States abroad. Medicine is much of the same everywhere, but the way that medicine is practiced is very, very different. And so that experience, I think, solidified the fact for me that I wanted to be in medicine. I knew that I wanted to make an impact to help populations in need. And I will tell you that my experience there was a huge talking point at my medical school interviews and with a lot of the people that saw my resume. So after my experience there, I knew that I wanted to get back closer to home. And as I said, I've always been a Pacific Northwest girl. And so I went back and finished up the remainder of my undergraduate years at Central Washington University, very close to home. And I was working as a medical scribe as I was finishing up my last 2 years of undergrad. So 2008 to 2012, I graduated undergrad in 2012. And then I decided to go into medical school. Now, medical school, there was lots of opportunities. Thankfully, I applied broadly, but as I was graduating high school, there was a medical school that opened up in my hometown, the same town that I went to kindergarten in, and that was Pacific Northwest University of Health Sciences. I learned more about it as I was abroad, as I was in undergrad, and I realized that that's the best place for me. I always knew that I wanted to impact a community that I was raised in, a community where I saw the disparities in healthcare, where I saw the need for more physicians. And so that was the perfect opportunity for me to join medical school there. Luckily for me, I also met my spouse before medical school, and we actually got married after our first year of medical school. We went through all of our medical training together, which was amazing. I couldn't have asked for a better partner throughout all of that. And we ended up graduating from medical school in 2017. So pretty much on track, if you would say, 4 years of undergrad, 4 years of medical school. Before we go any further, I do want to talk to you guys about the differences between a DO and an MD. And I'm sure many of you probably already know a lot of the differences as you're getting started in your pre-med journeys. But I wanted to talk about this because this was a big deciding factor for me. As you know, both DO physicians and MD physicians require 4 years of undergraduate education. They also require 4 years of medical school, whether it's osteopathic medical school or allopathic medical school. And they all require 3 board licensing exams. As a DO, you can take the COMLEX and or the USMLE. You can do both or one of them. And as an MD, you primarily take the USMLE. In addition to that, osteopathic physicians have over 500 hours of manual medicine training. And I can tell you right now that I use that training each and every single day. And the impact that it has on my patients is absolutely unbelievable. Also, one of the overarching differences is kind of the philosophy. And osteopathic medical schools were started with a completely different philosophy than allopathic medical schools, that holistic healthcare model. And that truly felt it was my personality. I knew that I wanted to go into medicine to have that relationship with my patients, to impact medicine in a specific way. And I felt that what better calling. In the same town that I grew up in, there was an osteopathic medical school that I felt so drawn to. So I decided to continue there. After 4 years of medical school, my husband and I graduated, and I decided to pursue family med residency. Now, I'll tell you a little bit more about the details of why I chose family med in a little bit, but my residency experience was truly amazing. My husband and I couples matched into residency. He actually went into internal medicine in the same hospital program. And I went into family medicine. I was able to interact with many of my colleagues. It was a small program in Northern Washington at Skagit Regional Health, but it truly provided me with like amazing opportunities. I met some of the most amazing people that'll be my friends for forever. In my second year of residency, we got pregnant with a little boy. And as I started my third and a chief year of residency, actually, I had a newborn. So it was quite the challenge, but I would not have it any other way. I think it made me a better doctor and a better person for sure. So as I was starting in my third year of residency, it also happened to coincide with March of 2020, and COVID happened, and COVID kind of threw this entire new realm into residency. I wanted to complete residency by doing a lot of the electives that I hadn't done yet, and a lot of the things that I felt like would make me a better family med physician. And unfortunately, because of COVID, we were all shifted into the acute respiratory clinics, and we had, very little control over our schedules. It was kind of a blessing in disguise, if I'm being truly honest. Though COVID was dreadful, and to see the impact that it had in our patients' lives was heartbreaking, to say the least. I feel like it definitely allowed me to gain exposure to a lot of the things that I would never see in a family med residency. So we worked in the acute respiratory clinics. We were diagnosing, swabbing patients with COVID. And this was the start. This is in March of 2020. We didn't really know a lot about COVID or how to treat it or, what the manifestations of COVID are, but that was a huge learning process for me. And I am truly thankful that it was incorporated while I was still in my training stages. I can't tell you that it has helped me as a family med physician now, dealing with a lot of patients who have had COVID or are being exposed to COVID. So fast forward to now. Now I am a board certified family medicine attending physician. I'm very, very passionate about preventative medicine, and I'll get into kind of why I chose family medicine. And preventative medicine was a huge portion of that. I practice a lot of women's health care. I do a ton of OMT, or osteopathic manipulative therapy. I do a lot of procedures, which I was very, very excited about going into family medicine. And you could say that I practice full spectrum medicine with the exclusion of obstetrics. I did get some great obstetrics training during my family med residency. I just felt like post-residency and the goals that I wanted and the lifestyle that I wanted, OB didn't necessarily fit into that. So I'm not doing that now. I work about 4 days a week in Bellevue, Washington, and I'm a part of a great group, so I'm really excited to be there. I'm going to go into the next portion here, which is going to talk about why I chose family medicine. So as I was getting started in my medical school journey, first year, second year, and into third year of medical school, I realized that I loved absolutely every rotation that I was on. People tell you that when you're in a specialty, you'll just know. And unfortunately for me, I loved everything. I loved my psych rotation and my peds rotation and my OB, and I even loved general surgery. I love that hands-on component. And I was talking to my advisors and, my fellow medical students, and they're like, well, maybe family med is the best option for you because you're so, into everything. And then I truly ended up falling in love with family medicine after doing several additional rotations in family medicine and seeing the flexibility that that field has to offer me. And I also mentioned the preventative medicine aspect of it. I went into medicine largely because I saw what the lack of access to primary care services can do to populations in need. I saw people get diagnosed with diabetes in the emergency department as I worked as a scribe there. And it broke my heart because the ER docs would say, well, go follow up with your primary care doctor. And a lot of the times those patients didn't have a PCP to go follow up with. So I truly wanted to be that person for these patients. I love the continuity of care that family medicine has to offer. I see grandparents and grandchildren and mothers, fathers, and sisters and siblings all day, every day. I get to create these amazing relationships with my patients, which truly are the motivating factor for each and every single day that I go to work. I mentioned the serving underserved populations portion of it, and I think that primary care is the first access to medicine that many people have, getting established as young as a child, and I wanted to provide those services to populations that didn't necessarily have access to that care. Family medicine has a ton of procedure opportunities, and I'll show you that soon as we get through the next couple slides. And it also provided me with the lifestyle that I saw myself in the future. I always knew I wanted a family, and I wanted to have that opportunity with the flexibility that family medicine provides. So I wanted to go over this briefly because it's a common question that I get. What's the difference between family med, peds, internal med, and med peds? And I'm sure you guys know this from all of the various presenters that have been here. But family medicine, you get to see infants, kids, adults. You do comprehensive women's health with procedures. There's options for specialization, and many graduates from a family med residency program go into primary care. Pediatrics is excellent in that they also see infants and kids, but they don't get to see adults. They don't get to do a lot of women's health, and there are options for specialization there. Internal med being the opposite, they see adults, but they don't see kids. Tons of opportunities for specialization. And med peds is kind of the merger of peds and internal medicine, where they see kids and they see adults. They don't do women's health at all, and there's lots of options for specialization there as well. So it's important for you guys to kind of look at, well, what are your goals and what population do you want to see and where do you see yourself falling into that? The next slide here is what can you do after you complete family med residency? And as you can see, there are a ton of fellowship opportunities. You could truly make your family med experience whatever you want it to be. A lot of my colleagues went into urgent care after doing a family med residency. Some people wanted to do additional fellowship year in obstetrics just to get their cesarean section skills up to date and feel more comfortable with those high-risk deliveries. But as you can see, ER fellowships, geriatrics, hospitalist medicine, hospice and palliative care. You can also go through like the public health route, research, pain management, truly endless options. And it's one of the residency programs that a lot of people don't know that you can still do fellowships and still specialize in. So I think that's the great part about family medicine because it provides you with that excellent like flexibility in your schedule and day to day. We mentioned the procedures, and truly the list of procedures can be endless. I do many of these in my office. So we do biopsies and skin excision lesions almost on a daily basis. People come in for mole and skin checks. Obviously, there's always a place for referrals and to send to dermatology if needed, especially with a high-risk family history or personal history. But oftentimes, they're just the small skin lesions that we can take off in the clinic ourselves. I do a lot of INDs and abscesses. People show up same day with complaints. A ton of women's healthcare, birth control, IUDs, Nexplanon placements, talking about various options there. I got excellent training in joint injections, so hips, shoulders, knees, we do a little bit of everything. And many people also do some minor surgical procedures like vasectomies and circumcisions. I did get training in vasectomies and circumcisions during my family med residency. I don't do them quite yet. I feel like I need a little bit more experience and exposure prior to doing that, but many family med docs do it. A ton of newborn and well child visits, obstetrics if you want to do that, including the prenatal, obstetric care, postpartum care. A lot of palliative care. So a lot of those conversations that we have with our patients about end of life and discussions about ongoing treatment and care. Tons of physicals for sports, summer camp things. There's a small portion of family med physicians as well who end up doing sigmoidoscopies, colposcopies, bone density studies. And then of course, many of us, if not all, do lots of those women's health procedures, pap smears, pelvic exams, mammograms. So the list is truly, truly endless. And in your family med training, you know, as long as it's a good program, you'll get access to all of these and exposure to all of these things. So I want to take you guys into a little bit of a day in the life, outpatient family medicine. Right now I practice Tuesday through Friday, 9 to roughly about 5 p.m., but I end up stopping seeing patients around 4, just finishing up tasks and notes and things. I see anywhere between 15 to 16 patients a day, sometimes more, sometimes less. With this COVID being a part of things, many of these have also been virtual visits, which are great as well. So I'm going to show you guys a little bit of my morning. So we're going to go from 9 a.m. to 12 o'clock, which when I take my lunch break, and we'll try to get through as many of these cases as possible so I can show you a little bit about what a day in the life of a family med doc looks like. So our first patient is a 16-year-old female, and she comes with a complaint of fatigue. And so we show up to clinic and we're getting prepped for her. We go in to see her in the room, and she is luckily a 16-year-old that you have seen before, and you've been doing her well child checks for quite a while now. And she comes in with her mom, and she's just complaining about feeling fatigued and worn down for the last 2 months or so. You ask her a little bit more questions and she's like, well, I feel like I have decreased energy. I just don't have the motivation to do anything anymore. She does have a pretty good history of depression and anxiety when she was younger, but she feels like she's coping well from that perspective. It's not an ongoing issue for her there. She denies being sexually active. Additional symptoms, she's like, maybe I have a little bit of a decreased appetite, but she's trying to hydrate as much as possible. She's not on any medications. School is going well for her. And that's, you know, she's just feeling drained. So it's a very broad picture of what's going on with her right now. But one of the most important things that I ask all of my teenage patients to do is I ask their parents to step out of the room. And I think that this is absolutely essential when we're treating a lot of adolescents, is to give them that privacy, to allow a family med doc to create that relationship, that safe bubble where they can disclose any information. And I'm going to go into something here. This is something that I was told very early on in my medical journey, and it's stuck with me to this day. So listen to your patient. They are telling you the diagnosis. In 2020, we have access to limitless resources, whether it's imaging, technology, laboratory studies. We can get answers within a few minutes if we wanted to. But the most important part, and I want you guys to all remember this as well, is that your patients are there for you, and they are telling you what is wrong with them if you take the time to truly listen and get that history from them. This quote here, the largest and least utilized healthcare resource is the patient, him or herself. So make sure you remember all of that, because it's easy to just view the patient as a statistic or a number or a list of symptoms. And so I want you to keep that in mind, especially as we go through all of these cases today. So the first thing, and recall that these are only 20-minute visits. And so in the first little bit, I am thinking of a differential diagnosis for my patient. So a broad differential, any sexually active or not sexually active female of childbearing age who comes into your office, the #1 differential should be on the list being pregnancy. We also think about anemia. Maybe her blood counts are low and she has heavy menses and that's causing some of her fatigue. Maybe she has thyroid disease, vitamin D deficiency, or perhaps this is something entirely different. Maybe she's getting sick and that's why she's feeling pretty fatigued. We talked about the depression a little bit. Perhaps it's not something that she's aware of, but it has been an issue before and it could continue to be an issue. Maybe she has a chronic disease like adrenal insufficiency or diabetes, an autoimmune disease, or sleep apnea. It's always important to consider all possibilities in your differential, because if you rule out something too early, that's a disservice to your patient. It's important to look into everything. So we keep that in mind as we go forward and we do our physical exam on her. She's generally well appearing, normal 16-year-old female. Her heart and lungs sound great. Her abdomen is non-tender. And otherwise, it's a pretty normal exam. So, you know, keeping our differential in mind, we think about the possibility of ordering some lab tests. And like I told you earlier, one of the most important things that you can do is keep pregnancy in your differential. So the first test that we want to order is a urine pregnancy test for her. And both the patient and or the mother may say absolutely no. And that's one of the reasons why I like to have that relationship with my patients and ask the parents to step out for at least a portion of the visit, is because I think it's so important to evaluate each person individually. And for her, she was able to actually disclose to me that she was indeed sexually active. It's just not something she felt comfortable disclosing in front of her mother. The other labs that I think about ordering, kind of working through my differential for her, are a thyroid hormone level, a blood count to make sure she's not anemic, vitamin D levels, and possibly like a metabolic panel to check her electrolytes, her kidney function, her liver function, to make sure all of that looks normal. So lo and behold, we get a positive pregnancy test for this patient. 16-year-old, did not want to be pregnant. This was her, you know, first encounter, and she was pretty scared when it came to this. So that's the first thing we got back. Now, we got back some of the other studies as well, and this was actually the next day, but I wanted to present them here for the sake of the case. Her thyroid hormones were elevated. They're at 10.8. Her T4 was within normal limits, which is the active form of the thyroid hormone. Her white blood cell count was normal. She was not anemic with her hemoglobin and hematocrit. And her vitamin D levels were quite low, but I remind you all that we live in the Seattle, Washington area. There's lots of rain and not a lot of sunshine, so a lot of my patients end up being vitamin D deficient. Her kidney, liver function, and electrolytes all looked great. So I want to talk to you guys a little bit about this, because I think that this will apply to every single patient that you see, breaking bad or good news, or even surprising news to the patient. It's one of the most difficult things that we do as physicians. Whether it's a cancer diagnosis or just something that the patient is not expecting to hear, it is so important for us as physicians to be well prepared when presenting this news. And as with anything in medicine, there's a nice mnemonic to kind of take you through that. So I'll go through these details with you guys. So the ABCDE mnemonic for breaking good or bad news. Advanced preparation. So it is absolutely essential that you have all of the objective and subjective data in front of you to present to the patient, that you have the most adequate and appropriate information. The second part of that is adequate time. So if you're rushing to give this patient some news that may surprise them or may scare them, that's a surefire way to, one, get your patient upset or just have them not listen to you. So it's hard in a primary care outpatient setting to provide that adequate time for patients, but I think that it is absolutely essential. So for this patient, it may mean, you know, pulling her aside, maybe having her wait a few minutes as I deal with an urgent issue, but knowing that I'm there for her and that time is uninterrupted. B, building a therapeutic relationship. I don't feel like many physicians outside of primary care are able to do that. And luckily for me, I'm able to have that relationship with my patients, because the majority of the time I've seen them more than once in clinic. We've gotten to know each other. They've developed that open relationship with me. So that is essential when you're presenting something that may be scary for them. Communication. This is key. This is so important. The way that you present the information is critical in the way that the patient takes it, the way that they react. I'll tell you guys a funny story, not so funny, about when I was a second-year medical student. It was actually during a shadowing opportunity that I had, and I had to unfortunately tell a family that they were likely having a miscarriage, and the emergency department doctor that I was with kind of pushed me into the situation, was like, "It's all you, go ahead and tell her." And with myself, you know, I have quite a bubbly personality. I'm a pretty happy person, and so I just went into that room and I said, "Hey, you know, we looked at your ultrasound. It looks like you're having a miscarriage." And she just broke down and started crying. And that was like my first experience in failure, I would say, in my medical career, where that was a horrible way to present things. And the ER doc I was with was able to give me some great advice, which I still hold on to, but communication is so, so key. Getting in the right frame of mind, emotionally preparing yourself will set you up for success, especially with your patients. So Um, D stands for dealing with patient and family reactions. Now, this is huge. You never know how the patient or the family will react, but allowing that support, knowing that they are able to ask you any questions, that you're there for them, that you'll walk them through that process is so important. And then E, encourage and validate emotions, whatever emotions that they have, knowing that they're in a safe space. This is a normal reaction. And oftentimes, I'll have patients come back for a follow-up visit, because many times that initial visit, they won't hear anything that you have to say, despite following, the adequate steps and going through that process. It's usually after going home and processing things that patients are prepared for that. So knowing this about our patient, it's important to broach the topic very sincerely. And luckily for her, I'll kind of tell you what that case ended up being like. I was able to talk with her. She was shocked, she was scared, she was crying, but she felt fine enough to tell her mom outside of that clinic visit. And the following week, we had them back in clinic, and we were able to come up with a good plan going forward, including getting her set up with a good OB doctor. But as we also noticed for our patient, she had some hypothyroidism in pregnancy. And so I wanted to go through this with you guys. Hypothyroidism in pregnancy is very important, and it's very important to be treated. So estrogen increases the amount of thyroid hormone binding protein that's available. And until about 20 weeks of pregnancy or so, the baby is completely dependent on mom's thyroid hormone. So untreated hypothyroidism in pregnancy can be very, very dangerous. It can lead to anemia, CHF, or congestive heart failure, preeclampsia, placental abnormalities, and even postpartum hemorrhage. So we take that very, very seriously, and we treat it very seriously. So for her, we calculate the dose of thyroid hormone that she'll need, and it's about 1.6 micrograms per kilogram, which amounts to about 100 micrograms per day. So we get her started on that pretty immediately. We'll want to do a repeat thyroid stimulating hormone level in about 6 weeks, and then we check her thyroid hormone levels very closely every trimester, if not even more than that, as it can fluctuate a lot with pregnancy. And as with many of my patients here in the Seattle area, I get her started on vitamin D, 2,000 international units of vitamin D daily to prevent, to sustain, a healthy pregnancy, but also, perhaps that's the reason for her fatigue. And it's, not necessarily the pregnancy, but there's multiple different factors, as we can see with her. So that is the completion of our first patient. It may have taken a little longer than 20 minutes, but it's totally worth it in the grand scheme of things. And we're going to get started right into our next patient. Our 920 patient is a 24-year-old female, and she's here to discuss birth control options. She had a recent change of partner, and she tells me, "Doc, I do not want kids anytime soon, so I need your help to find a good birth control option for me." So when we think about birth control for a patient, it's very important to consider each individual patient themselves. So what are their goals? What are their fears? What has been their previous history with birth control use? And that conversation will really guide my recommendations and birth control options that I present to my patients. For example, our 24-year-old here tells me that she has tried oral contraceptive pills in the past before, combination estrogen and progesterone, and oftentimes she completely forgets to take them. She says that it's on the side of my drawer, and every night I forget to take my pill, and I can go a week or more without taking it. And as we all know, that is not an effective form of contraception. It does not fit with the patient's goals of not wanting to have kids anytime soon. And the fear that she tells me about birth control is she's very afraid of that commercial that she saw on TV about that rod being inserted into the arm of a patient. So she says, absolutely not, I don't want that one at all. So we go into various options for birth control, and I think this chart does a great job of looking into each one. So we know that our patient's goal is not to get pregnant anytime soon. And so we want to think about long-term options for birth control. And that's the first row that you see up there. The other word for these are LARCs, long-acting reversible contraception. And she already told us her fear about that Nexplanon, or the implant in the arm. So we're not going to discuss too much about that, because there's many other options. We talk about IUDs with her. So there's a Skyla Iud, which is for 3 years, a Mirena IUD, which is a hormonal IUD for 5 years. Paragard, which is a copper IUD, no hormone in it, but very effective form of contraception. And then of course there's sterilization, getting your tubes tied, other options for that. And that's a forever option. So definitely not an option that I'm bringing up with her today, at least. So the options that are most interesting to her are the IUDs. She's heard about a couple friends who've had it in place before, and she's very interested because the chances of getting pregnant with an IUD or one of these long-acting reversible contraceptive methods, it's less than 1 in 100. And so very, very good form of contraception. We talk about various options for her, and we decide to proceed with the Skyla. The Skyla IUD is a smaller IUD than the Mirena, probably more preferred for somebody who has not had children before, and it's a lot easier to insert into the uterus. I do go over the other options with her just so she knows everything that's on the plate here. The pills, which we know that are not a great option for her because you have to take it every single day and she's not so good at that. The patch, probably not a great option for her either. It's a patch that goes on top of the skin. You have to change it every single week. And so it is something that requires your interaction and staying on top of. The vaginal ring, we brought up that option. She was not very excited about it, but it is effective. You know, you put a ring into the vagina and every month you remove it after a menstrual cycle. The depot shot, she was terrified of the depot shot because she's heard that it causes a lot of weight gain. And so she was not very interested in that as well. And as you can see, although these are all great options, the second row, there's still about 6 to 9 in 100 women that could get pregnant on these options. So it's always important for the patient to be well informed about all of these decision-making things. As we get to that last tier, these are options that don't work very well for contraception, and I truly don't recommend them. They can result in pregnancy up to 24 women in 100, which is a large, large number. The withdrawal method, the diaphragm, fertility awareness, and condoms. So the most important thing to remember that with all of these methods, condoms aside, nothing prevents against sexually transmitted infections outside of condoms. And so that is a talking point for every single patient that I talk to about birth control. And it's definitely one that we discuss with her about. So we decide to do the Skyla IUD for her, but first we have to do a urine pregnancy test because it is absolutely essential before placing any form of contraception that we have a negative urine pregnancy test. She had also mentioned that she had a recent change of partner, and so we're going to do an STI screen or sexually transmitted infection screen on her as well. And of course, reiterate the fact that IUDs do not prevent against sexually transmitted infections, and condoms are truly the only way to prevent that. So what we could traditionally do is we could say, hey, you want the Skyla IUD? Let's have you come back when I have my next opening, which could be in a couple weeks or it could be in a couple months. And I will tell you that as a primary care doctor, when I'm treating kind of the adolescent population or really any population who is at risk for an unintended pregnancy, I will put that Skyla IUD in same day as long as there's no contraindications for it. Unfortunately, throughout my residency training, I did have a patient that wanted an IUD. We didn't have an opening in the schedule. We booked her for 2 weeks later, and she ended up getting pregnant in that time frame. And so if you're able to do it the same day, that is obviously the goal. The patients are going to appreciate it, and it's going to save an unintended pregnancy, which is definitely the goal for myself and for the patient. So that is that. We are moving right along to our next patient case here. 65-year-old female. She has chronic left knee pain for the last 6 months or so. She says it just has been killing her. There's been no injuries or falls. She went for a long walk with grandchildren last week, and it was much worse. And occasionally it swells, but it's kind of right in that middle half of her knee, and she's just holding it in pain. So for all of my patients, you know, starting off with a physical exam is definitely what we recommend. And for her, she's a little bit restricted in her range of motion. She can't fully extend the knee without pain. She can't fully flex the knee without pain. She definitely has pain with internal rotation of the knee, but there's no obvious swelling, redness, or real tenderness to palpation that I can elicit on exam. She just has a lot of pain with kind of medial motion of that knee. So first and foremost, 65-year-old female, the first thing that I think of, you know, could this be arthritis? We see that unfortunately very common, especially when we talk about chronic knee pain, nothing acute, nothing that's happened recently in the last day or two. But because I'm suspicious that she has arthritis, we go ahead and order an x-ray. And this x-ray will kind of already show you the results, but I want to talk to you guys through it. As you can see, the x-ray on the left shows a very healthy, beautiful looking knee. That joint space that you can see between the bones of the knee, that is a healthy joint space. We want to make sure that that joint space is there. There's enough cartilage. And now you can see her knee on that right side. And it does not take a physician to see that that knee is completely destroyed, especially that medial aspect where she's bone on bone. She's eroded through a lot of that cartilage. She has a lot of bone spurs in that area as well. The lateral side looks a little bit better, but not by much. So she has a knee that she essentially needs a joint replacement for. So I talked to her, we pull up the knee x-rays. Thankfully for me, I have an x-ray department in my office. And so it's just a quick walk around the corner. She gets the x-rays done. I pull them up on my screen and I'm able to talk with her about it. I do, sometimes wait for the official radiology read, but oftentimes it's something that I can easily read in my office and talk to patients about. So we talked to her about the possibility of needing a joint replacement in the near future, and she is terrified. She tells you that her husband actually died during surgery for a hernia repair, and she's terrified. She absolutely does not want surgery. But she's in a lot of pain and she wants pain relief, and she wants pain relief today. And luckily for me, I have a lot of joint injection training, and I'm able to offer her a joint injection that has a combination of steroids and some anesthetic in it to help relieve her discomfort. So we use Kenalog, which is a steroid, bupivacaine, an anesthetic, lidocaine, an anesthetic. We put all of that into a 25 gauge, 1.5 inch needle. I'm able to do it right then and there. It takes about a minute. I prep the injection site, and as you can see with that image, that's essentially where I insert it into. That patient will have pain relief same day, but that's primarily from the lidocaine. So that's a temporary pain relief that she'll have. That steroid is what's going to give us the bang for the buck. So that steroid will act in several days to weeks to help reduce the inflammation and help the patient be a little bit more comfortable. Now, as you guys may know, this is a temporary option. This is not going to save her knee. It's not going to reverse her arthritis, but it will get her to a point where we can get her back into clinic and talk to her about the pros of getting a joint replacement, what the recovery looks like, referral to a trusted orthopedic surgeon. And that process can take a couple visits before the patient's in that mindset. But fortunately for us, that steroid can last anywhere between 3 to 6 months and provide her with some additional pain relief until she needs that surgery. So truly grateful that I'm able to do these immediate procedures for my patients, get them that relief, but also come up with a long-term plan for them, because we know that this is not something that's temporary. So moving right along, we have a 45-year-old female. She's here for a diabetes follow-up. This is bread and butter primary care. Hypertension, diabetes, we see it all day, every day. And so she is going over her fasting blood sugars with me today. She tells me that it's just the holidays, doc. We had Thanksgiving, we had Christmas. This is a horrible time to come back into the office. And I agree with her. It can be really tough, especially during COVID. But she tells me that she's not at goal yet. Her last A1C was 8.5, which gets us a little bit more concerned. And we come up with an active plan together. She's on metformin, 1,000 milligrams twice a day, as well as sitagliptin, 100 milligrams daily. So we talked to her about our goals for diabetes. Our aim is for a hemoglobin A1C of 7 or less. And a hemoglobin A1C is the average of the fasting blood sugars over the last 3 months. And so it gives us kind of that general picture of what do the last 3 months look like. And for her A1C is definitely higher than 7. So our goal for her is a fasting blood sugar in the 70 to 130 range. We don't want it to go above 130 because we know that leads to poor outcomes in patients with type 2 diabetes. We also want her postprandial or her after meal blood sugars to be less than 180. And so we talk a little bit about dietary modifications, the recommended number of carbohydrates per meal, 150 minutes of vigorous exercise. So getting that heart rate elevated, which I tell all of my patients about. It's hard to do, but it's certainly well worth it for your future health, your cardiovascular health. And so, I spend a good 15, 20 minutes counseling her on all of this. And as with anything in primary care and medicine, I reach for the door handle and she says, "Oh, doc, wait, by the way, I forgot to tell you that I've been having some chest pain." Well, chest pain, you should have mentioned that the first thing that we walked into the room. But of course, chest pain is never something that we ignore. And so we have to spend a little bit more time with this patient to talk about her chest discomfort. So she describes this as kind of an upper abdominal pain or pressure. It's present with activities. She occasionally gets short of breath with it. She says, sometimes I'm out walking with my husband and I just can't walk, more than a few blocks. It goes away though. I feel like it gets better when I sit down and rest. I guess I'm just getting old, doc. This just must be something that, is because of old age. Unfortunately, something very, very common that I hear, and majority of the time it's not because of old age. Heart disease is the #1 killer of women in the United States. It is shown that many women often ignore symptoms and they account them to be due to less life-threatening conditions like acid reflux or the flu or normal aging. So it is absolutely essential that we address her complaint today and let her know, the severity of our concerns. What she's describing here with that exertional pain and shortness of breath, she's describing stable angina. It's triggered by physical or mental exertion, resolves with rest most of the time, or nitrates, which are vasodilators, improves that blood circulation. Other, various forms of angina are listed on there. Unstable angina, that's definitely something that we get a lot more concerned about. And all of these require specific workup and evaluation. So for her, I decide to do a cardiac stress test on her. We order it. Obviously, it's not something that we do same day, but she's stable enough at this point that she's not having active chest pain that I think an outpatient workup is appropriate. Pending the results of that, she may need further studies like a coronary angiogram or a catheterization where, they have to actually look at those vessels to see what her risk of having, a heart attack is. So I'm glad that she mentions that today, though it does throw off my morning schedule just a little bit. It's important to address this, and she'll definitely come back to me for a close follow-up visit so that we can go over her results and keep an eye on this. So moving right along, we come to we're winding down on our last morning patients here. And this is a 38-year-old male. He tells me that he's feeling down. He's been working at home due to the pandemic. His hours were cut down, but he feels like he's even working more because he's working primarily at home. The kids are at home. It's hard to focus. He feels like he's always fatigued. There's decreased motivation. He feels very short-tempered. He does note that there's a history of depression that he had as a teenager, and he was probably on some medication that he doesn't really remember. He's on omeprazole 40 milligrams daily for his acid reflux, and he's also on lisinopril 20 milligrams daily for his high blood pressure. And he's like, what do I do, doc? Well, luckily for me, my medical assistant was able to give him a couple questionnaires before I even saw him. And these questionnaires I'm going to go through with you guys. The one on the left is a PHQ-9 questionnaire, which is a depression screening questionnaire. And the one on the right is a GAD-7 or an anxiety questionnaire. And the patient is able to fill both of these out probably even before I see them, or sometimes I go through it with them. And this kind of gives us objective data to look at. Now, we already know his symptoms are very concerning for depression and or anxiety, but these give us some numbers as to go off of to say, well, how severe is this? And what treatment options do we consider for him? So this is the score interpretation, and you can see based on the scores, the severity, what is recommended for them. Unfortunately for this patient, he had a PHQ-9 score of 16 and a GAD-7 score of 12. And so he fits into that moderate to severe category. In any one of my patients that have any sort of depression or anxiety, close follow-up in my clinic is absolutely essential. For all of these patients, I make sure that they follow up in anywhere between 2 to 4 weeks. But for this patient, we talk about, the possibility of starting counseling first and foremost. I think that's absolutely recommended for all of my patients. And then we go through kind of various medication options. All of my patients, I also talk about a lot of cognitive behavioral therapy options that are available, journaling exercises, breathing exercises, things that they can do at home to help with their stress and anxiety. I make sure that they have a good support system at home. And of course, we always ask those screening questions about suicidal ideation. This patient is gotten to the point where he is very much interested in medication options. He feels like he's unable to cope without them. And so we kind of go through various options, SSRIs, non-SSRI type medications for him, including a lot of the Side effects. So side effects are so important to go through for a lot of these because many times the patients are just unaware of them. And unfortunately, with a lot of the antidepressant options that we have available to us, the side effect profile can be quite hefty. So I go through some of the SSRI side effects for him, and he tells me that absolutely not, sexual dysfunction is not something that he is willing to cope with. And so he pretty much eliminates all of those options first and foremost, and that's important to his mental health. So we talk about an option like bupropion or Wellbutrin, which does not have the sexual side effects. It may provide him with some benefit, and he's on board with that. And we decide to initiate Wellbutrin, do a close 4-week follow-up visit with him, at which time we'll repeat the PHQ-9 and GAD-7 scores, knowing that it can take 4 to 6 weeks before any SSRI or SNRI is even effective. So it takes time for these medications, but in the meantime, we're going to give him resources, make sure that he has a good counselor, somebody that he can trust. Mental health is also bread and butter primary care. Now, there's plenty of psychiatrists out there, and unfortunately in our area, it's actually very, very limited. There's 3 to 6 month waits to see a psychiatrist. And so oftentimes that role falls upon primary care doctors, and I discuss it with each and every one of my patients. I can tell you this pandemic has presented so many challenges to all of us. I mean, you guys are here doing virtual shadowing. You know, my residency was impacted due to the pandemic. And so this pandemic has impacted all of us. And I can tell you that it's a part of each and every single visit of mine, taking the first few minutes to ask my patients how they are doing and how they're coping with this pandemic, because it is truly one that has been difficult. So our last patient of the morning, you guys, we made it past a crazy morning, but it was wonderful. So this is a 32-year-old female. She's coming in to see us with some low back pain. She says it's just been ongoing since she delivered her baby about 6 months ago. It was present throughout her entire pregnancy. She occasionally feels like it radiates down her left leg. It's not present all the time. And she has, quote unquote, tried everything. She's like fed up and done. She's done ibuprofen, Tylenol, muscle relaxants, physical therapy she did for about 12 weeks, did not find that as effective. It did help her in the interim, but nothing that she was able to cope with. And she is hoping for some immediate relief today. So acute back pain is one of the most common reasons for people to come see a family medicine physician. So I am so lucky that I got training as a DO in osteopathic manipulative therapy, because I can tell you, as being one of the most common reasons people come to see a family practice doc, I am able to give them a treatment right there in the office that provides them with so much pain relief that oftentimes we don't even talk about medication options. So I decided to do some OMT for her. And I'm sure you guys have heard OMT. I know you've had lectures in the past who've talked about OMT. So I'm just going to briefly go over it with you. We do a physical exam, and an osteopathic physical exam more specifically, starting off with just a visual inspection. What does the skin look like? Is there redness? Is there areas of obvious asymmetry? And I check range of motion, flexion, extension, side bending, internal and external rotation. I feel the spine, I feel the surrounding musculature, the bones, the ligaments, you know, the superficial fascia. I also do a neurologic assessment, you know, with that shooting pain down her legs, you know, what nerves are involved, what distribution is it? And then depending on what dysfunction that I note during my physical exam, I treat it with OMT. I use a number of various modalities, all of which I've been trained in, used throughout my residency training and here as an attending. And I'm able to do, you know, a myofascial release for her, use muscle energy, do HVLA, fix her sacrum and her pelvis, which are oftentimes dysfunctional, especially after pregnancy in that postpartum period. And this is, you know, this is an example of a true patient that I've had in my clinic, and the amount of relief that these patients have after, you know, not only one, you know, but a few treatments. Sometimes just one treatment is absolutely amazing. You know, they're so thankful with what I'm able to provide. I also give these patients, you know, a list of exercises and stretches that I want them to do regularly at home. Many times I often refer to physical therapy to do in combination with OMT. And then of course, you know, ibuprofen, Tylenol, NSAIDs, ice, heat, all of those things are things that I recommend for everybody. But it's an excellent tool that I'm able to utilize with my training. That I feel like makes me a better doctor for my patients. They truly come back to me with just ranting and raving about OMT in general. So even though I've only been practicing for a short period of time as an attending, I can tell you that many patients are already being referred to me purely for my OMT services, which is excellent. So that completes kind of our morning, but I wanted to go into some of the most common diagnoses in primary care. And you guys can look at the list. There's a lot on there. We mentioned hypertension, diabetes, high cholesterol being right at the top of the list, back pain, anxiety, or just mental health in general. And as you go further down, you can see that we do a little bit of everything and literally every system of the body. I am truly thankful that my training in primary care has prepared me for this, but I truly feel like I can help patients in a little or a grand way as possible. There's always something that I can do for them to help provide them with relief and counseling and getting to them to feel more confident and happy about their healthcare as a whole. Oops. Skipped a couple here. I wanted to go into the lifestyle of a primary care doctor. So you guys know the flexibility, and I hope that's been made aware throughout my presentation today. The flexibility in family medicine is truly one that you can't find in all fields. I am able to decide the hours that I work, how much I work, whether it's part-time or full-time, how many days a week I want to work. The location, you can truly be a primary care doctor wherever you want to be. There is a need for primary care wherever you want. It's not like certain specialties in high cities and places like that where you can't find a job. I can tell you that I had plenty of job opportunities immediately after residency. And so that was great. I was able to choose a town that I really wanted to live in. You're able to do what you want. So if you don't want to do OB, you don't have to. If you don't want to see kids, you don't have to. If you don't want to do procedures, you don't have to, but you have the option to do all of that. And many primary care docs also, find their focus, whether it's women's health or whether it's obstetrics, or they want to focus on sleep apnea or something, you're able to do that. You're able to create this so-called niche and focus patients and see patients primarily based on that. There's very limited call. I think I'm on call once a month, if at that. And there's no after hours services unless you're in OB, of course, then you will get called in for a delivery. I mentioned that there's a need for primary care wherever you will go. And I can tell you that this field is so incredibly rewarding. The relationships, the impact that my patients tell me that I'm having, that I can see that I'm having on my community, it truly makes it all worth it. All the long hours throughout residency, all the long hours now, it is totally worth it. And with that, there's always room for your other life goals. I always knew I wanted to become a mother, and I wanted a family, and I wanted to be, active, being an active parent at home, and I can do that. I have lots of hobbies, so I love to read and listen to podcasts and go hiking, and I truly have the time to do that post-residency. Residency is always a difficult time period for everybody, but post-residency, I truly feel like the lifestyle allows me to do whatever I want to do, so I'm excited about that. So that is about it, you guys. Thank you so much for joining me. I hope you learned a little bit of something about family medicine. I put my email information up there. Feel free to email me. I'm also fairly active on Instagram. I'm at Married in Medicine. So send me a direct message. I can tell you I get them each and every single day, and I will respond to all of them if you have questions about pre-med, about family medicine in general. And I wanted to end off with this quote here. You are capable of more than you know. Choose a goal that seems right for you and strive to be the best, however hard the path. Aim high, behave honorably, prepare to be alone at times, and to endure failure. Persist. The world needs all you can give. Thanks, guys.
Thank you so much. This was such an amazing presentation. I think now if you open the chat, you can see the messages, all the thank yous.
Yeah, I'm happy to, if I can find the chat.
There's a lot of people saying that you've really made them consider family medicine, to look into it more. So thank you so much for giving all your advice.
Yes, of course. And if I am able to answer any questions for you guys offline here, seriously via email, my goal is to convert all of you guys to family medicine, or at least show you the options available as a family med doctor. So I'm available.
Thank you. I guess we can maybe do just a couple of questions before the hour is up. I think one of the questions that a lot of people wanted to know was, when you were talking about your first patient, the young girl,
Mhm.
how do you deal with those kinds of patients, especially with like, of course you have your patient confidentiality, but when they're minors, kind of is that a case by case basis, or
Yeah.
how do you go about that?
That's a great question. Patient confidentiality, first and foremost, is something that we all value, not only as primary care docs or family med docs. It is something that is sacred in medicine. And you're right, she is a minor, but it's the laws surrounding being a minor, especially when it comes to contraceptive health, to sexual health, having access to vaccines, those types of things. The laws do not apply to confidentiality in that manner. Now, if I felt like her life was being threatened, that she was at risk for harming herself, obviously it does not apply, and I would definitely get her mom and other family members involved in that. But confidentiality certainly applies to her situation, and that is something that can remain between myself and the patient. There's no need to disclose that information to anybody else.
Great, thank you so much. We also had a question kind of earlier on. We had some people very interested in your residency and wanting to know, what it entails to be a chief resident and how you got to that.
Yeah, great question. So chief residents have a little bit of a different role when it comes to their last year, and sometimes it's even an additional year that you do after residency. It is something that your peers select you for, your faculty, they obtain all of your evaluations from the first few years of residency to make that decision for you to be chief. It requires a lot of work, and it does mean doing scheduling things, making the call schedule, being available for your co-residents should an issue come up. You kind of serve as that, not necessarily authority figure, but you're that point of contact before they go to the program director or somebody else. And so I was slightly hesitant. I was a new mom in that role, and I didn't know how I would fulfill it, but I knew that leadership was something that I was always passionate about. I was in leadership positions every single year in medical school, and I knew that that was something that I wanted to do in residency as well. And so I was hopeful to take that on, and I think that it was totally worth it for me. I will tell you that and it's something that I want you guys to be aware of, because it certainly brought up a lot of additional opportunities for my personal growth and for my job growth. Like, I get asked about it on every single interview. Tell us your, experience with being a chief resident. It certainly puts you apart in a certain way. But I think my personal growth more than anything, I'm able to have difficult conversations with my peers because I got training in that. We go through a chief resident conference every single year where we get to meet different chiefs from across the region, and that experience teaches you a lot about leadership in medicine, leadership in the workplace. And so if you are ever able to consider that option, I 110% recommend it, despite the increased workload.
Great, thank you so much for that explanation. I think another common question that we had towards the beginning again was if you could describe in depth a little more what couples matching is. I think there was a lot of people that were kind of confused on that.
Yes, of course. So couples matching is a process where you are tied to another individual, and you don't have to be married. It can be your best friend or your boyfriend, girlfriend, whoever. You're tied to another individual in the match process. And so I don't know if you guys know a lot about the match process, but you may have heard about it. It's where we basically apply for residency. And so we rank our list based off our number one choice all the way down to our 50th choice, if you will. It depends on how many places you interview at. And your match list is identical to your couple's match list. So whoever you decide to go into the couple's match list with, which means that if one place likes you but doesn't like your spouse, you're not going there. So they keep going down the list until you find a match where they like you and your spouse. Luckily, and very, very thankful for me, they liked both of us, and we ended up at our first option. But it is kind of a scary process to bank all of your training and education and hard work with somebody else. And like, I mentioned, my husband and I went through medical school together. We studied with, every single step exam together. We took all of our exams. And so it was definitely something that we wanted to do. The risk being that we would end up in different places had we not done the couples match. And that was just a risk that we weren't willing to take. So if it meant we went down on the 10th option of our list, it was still worth it for us. Thankfully, we didn't have to do that, but it is something that you're just tied to another individual, and it can be a risky situation. There were couples in our class who didn't end up matching together for that reason. So it's tough. Luckily, we both are in vastly available fields. He's internal medicine, I'm family medicine. There was a lot of opportunities for us. I can tell you it's probably not the case for orthopedic surgery or dermatology or something. So it's something to think about and consider.
Thank you so much for explaining that, because we know a lot of people have questions and a lot of people don't know about that. So it's great to hear about couples matching. I think we are going to ask one more question, and that's just, as we are hopefully ending the pandemic with everyone starting to get the vaccines in the next few months, what advice would you leave us as pre-med students in kind of navigating through a pandemic and trying to do our best?
Yeah, you guys, you're in such a difficult stage, and I truly commend you. I think this opportunity here is absolutely amazing. I say take every single opportunity, no matter how big or how small, to put yourself out there. As a pre-med student, we want to see people who are active and engaged and wanting to learn and wanting to do everything to get into medicine. You know, medicine's a difficult field, but I think that if you can show that you have the motivation and the desire to succeed in medicine, that's truly all it takes. So try to be engaged, whether it's, you know, through your local church or doing small things, volunteering at a COVID vaccine clinic, or, you know, doing these small things, or showing that you're participating in sessions like this to learn more about medicine and learn more about various opportunities. That's going to speak volumes. You guys are in a special stage in this process with COVID. And I can tell you that will be taken into consideration, you know, but as long as you're showing that you're trying and you're doing various opportunities, I think it's going to take you places for sure.
Thank you so much. We loved all that advice. We will definitely take it. We loved your enthusiasm, and we really felt the passion that you have for family medicine. So thank you for sharing that with us today.
Oh, well, thank you guys for having me. I really appreciate it.
Of course. And we will keep in touch with you, and we hope you have a great rest of your day off.
Thank you.